Check. Check, check. Halo, halo, check. Check, check. Halo, halo, check. Check. check, check. Hello, hello, check. Hello, hello, check. Check. Hello, hello, check. Check one. Check. Check one. Hello, hello, check. The மேல போய் பேசு. Hello.
Good afternoon. Good afternoon. Good afternoon to everyone present here. We've gathered here to attend a guest lecture on sleep surgery. I request Dr. Anand sir, Professor Dr. Karthikeyan sir, Professor Dr. Shrikant sir, Professor Dr. Vijay Sundram sir, and Dr. Nikhil sir to kindly come up on the dais.
I now request everyone to stand for the SPV anthem.
Education gives humility. Humility gives character. From character, one gets wealth. From wealth, one gets righteousness. In righteousness, there is joy.
I request Professor Dr. Shrikant sir to facilitate our chief guest for today, Dr. Anand, with a bouquet.
I request Dr. Nikhil sir, Assistant Professor, Department of EAT and Secretary SAF for the welcome address.
Warm good afternoon to one and all. Today is a really memorable day for all of us. We all have assembled here to get enlightened by Dr. Anand sir, who will talk on sleep surgery. My pleasant duty today is to welcome all of you assembled here to this academic feast. We are fortunate to have Dr. Anand as our guest speaker, who, in spite of his busy schedule, have traveled all the way from Coimbatore and agreed to spend this afternoon with us and share his treasure of knowledge and experience with us. Sir, on behalf of all assembled here and on behalf of SAF, I welcome you to this program. I would like to welcome Dr. M. Sarvanakumar sir, Senior ENT Consultant from Pondicherry, to this August gathering. Welcome, sir. Now let me welcome our most respected professor and head of department, Professor Karthikeyan sir, who is a driving force behind the success of this program. Sir, on behalf of all assembled here and my personal behalf, I welcome you to this program. It's my pleasure to welcome Professor K. Shrikant sir, President SAF. SAF is performing well under his dynamic leadership. Sir, I welcome you on behalf of all assembled here. I also welcome Professor S. Vijay Sundram sir, Senior Professor, Department of ENT MGMCRA, to this office. Welcome. Now let me welcome all the senior faculty members of all the other departments, Department of ENT, postgraduates, interns, and students who have assembled here to attend this meeting. Once again, welcoming all and wishing you a wonderful day. I remain. Thank you.
Thank you, sir. I now request Dr. Karthikeyan sir, Professor and Head of the Department, to introduce our guest speaker.
Good afternoon and warm welcome to everyone gathered here. I am profoundly delighted to take this opportunity to introduce the chief guest for the day, Dr. Anand Raju, very good friend of mine, a renowned ENT practitioner, senior consultant, and managing director at Anand ENT Hospital, Coimbatore and Tirupur. He is known for his work in the field of cochlear implant and sleep surgeries. He is a visiting professor and head of cochlear implant and sleep surgery department and PSG Hospital and Medical College, Coimbatore. He took his training under world-renowned surgeon, Padma Shri Dr. Mohan Kameshwaran sir, Chennai. And he is a member of various associations like International Sleep Surgery Association, World Sleep Congress, and European Police Society. He has published many articles in national and international journals. He presented many scientific papers in the national and international conferences and conducts regularly hands-on cadaver workshop in his own place. He was graduated from Madras Medical College, Madurai Medical College, Madurai, and it is honor for me on behalf of everyone to extend our special welcome to our guest speaker, Dr. Anand. A good laugh and a good sleep are the best cures for anything. Dr. Anand gives good sleep by doing a sleep apnea surgeries. We are delighted to have your presence with us, Dr. Anand, and we would like you to share upon the light of knowledge to everyone. This session will be moderated by Dr. S. Vijaysundaram, Professor of ENT MGMCRI. So over to you, Dr. Anand.
So, sleep surgery is not a new one actually. So the sleep surgery we are doing for almost more than 15 years, but still is not well recognized by a lot of our colleagues actually, because actually always the sleep surgery going to be failure. So even though we do a proper surgery, proper surgical method, definitely. So the awareness among the patients are very poor. So as well as the post-operative management, post-operative follow-up is also very important for get a very good result in sleep surgery. So now I'm going to talk about so patient selection of proper method, how to approach the patient, and with various surgical methods to suit for which surgical case actually. This is a basic topic, not a very advanced one. எப்படினாலும் ஓகே தான், அங்கேயே தான் ஓகே. ஜஸ்ட் ஒரு அப் அண்ட் டவுன். ஓகே. It's okay. It's okay. Volume. Volume. Audio way. Open it. So small video. The video is clear. The screen is clear or not? Not clear. No. surgical methods so far actually give a 100% result without proper patient follow-up actually. So 100% results in sleep surgery, is it possible? No, not at all possible. So this is an overview. So selection of patient, the importance of sleep study, and diagnostic sleep endoscopy, and selection of proper surgical method, and always a multi-level surgery. Single surgery is not enough to give a cure. Multi-level surgery, and what are the reasons and wants. So successful surgical outcomes always depends on all these three steps actually. Systematic preoperative evaluation. So that is very, very important. Actually, poor selection of case, definitely you will land in a 100% failure. Choice of surgical technique and post-operative management. This post-operative management is very, very important actually. So without proper post-operative management, you can't give a good result. The causes of failure in sleep surgery is three P's actually. Poor diagnostic technique and poor selection of cases. So I think, so how many of you snore at night? Nobody? So everybody, we used to snore, even very tired, this thing. Sometimes the snoring is very severe. So selection of cases is very important, and poor diagnostic section, definitely we will land in a problem actually. Then poor selection of cases and poor selection of surgical method. The last one is very important actually. So straight away we can't do just remove the tonsil and just remove the uvula, won't give a proper result. So selection of patient. So we know that actually. So the screening is very, very important. Screening always we have to ask the question to the partner, not to the patient actually. The patient they won't know. So how severe the snoring is actually. Is anything choking? They won't know. Only we have to ask question to the partner. Then otherwise, the leading questions like this, suppose how does morning freshness and daytime sleepiness, as well as headache and the loss of energy, all these history and the raise of blood pressure, all these history the patient used to give. Sometimes we have to ask the patient, but simple snoring definitely don't do any surgery. Just advise them go for a walking and weight reduction and simple myofunctional therapy. Definitely they will do better. So for severe snoring, when the BMI is very high and our sleep study. The next one is actually this is routine examination. So general appearance, weight and height, blood pressure. Normally for all surgery we do this. For actually sleep surgery, we do thyroid evaluation and hormonal study also. Sometimes cranioimaging, morphology also we do. The selection of patient actually in the first picture. So this patient, so we can give a very good result. This type of patient also we can give a very good result. But the last patient, BMI is more, as well as the belly fat is very high. Definitely, we go to work before surgery as well as after surgery. Definitely, we have to do surgery for him, but so we have to give a counseling, proper counseling. There won't be a 100% result. Definitely, we can reduce the snoring, we can improve the oxygen desaturation index, apnea, hypopnea index, but we can't give a 100% result. This type of patient also, the surgical method is very important. It's a very thin patient, BMI is very less, but facial morphology is different. The receding chin, so we have to select proper surgical method to give a proper result. So this type of patient, all these patients, so you have to select proper surgical method to give a proper result. Facial deformity, associated problems like thyroid, congenital, hormonal, everything we would assess before surgery. So short, thick neck, collar size suppose is more than 17.5, so also give a problem actually. Enlarged fluffy uvula, elongate soft palate, tonsillar hypertrophy, enlarged tongue, the residing this mandible. All these factors you have to assess before surgery. So this is a normal throat. Okay. So the lateral walls also very apart. So there's a normal uvula. So both pillars are so actually in the adequate position actually. So this much of space is very good. This is a normal throat. See in this patient, the huge tongue. Huge tongue. We can't see the uvula, we can't see the posterior pharyngeal wall. So Down syndrome, the patients actually they have a huge tongue. A lot of patients. So you have to assess proper. Straight away look for the tonsil and uvula. So not going to give you stuff. Huge
huge tongue, so always keep it in your mind actually. So this tongue is going to be a problem. Suppose you select this case. So this case actually elongated uvula and lateral collapse, huge tonsil, grade 3 tonsil. So velopharyngeal collapse as well as oropharyngeal collapse is there. So this patient actually tonsils is very less, but it is posterior pillars actually are there. So almost touching together. So this collapse, oropharyngeal collapse. This tongue is also a little big. So assessment is very, very important. ENT examination is very, very important before going into surgery. So the physical examination includes the measurement of 4 parameters. This one is modified malomorphic rate. So always our anesthetist used to do before intubation, tonsil size and body mass index and thyroid mental distance and thyroid mental distance. Nowadays, actually, lot of soft pellet surgeries, soft surgeries. So we are not worrying about this distance actually. So we can assess with the diaphragm sleep endoscopy, and we can do a lot of soft pellet advancement. We can give results without any bony work actually. In some patients, definitely we would access the bony work. Otherwise, we can't give a good result actually. So everybody knows about Muller's maneuver actually. Everybody knows about Muller's maneuver. So suppose don't know, go and study about Muller's maneuver. Previously, nasopharyngeal scope through the nose, and we'll ask the patient to the Muller's maneuver, and we see the lateral wall collapse as well as collapse of the airway. Is a very good predictor for actually surgical outcome. But nowadays we are not predicting actually. This is one is taking as Muller's maneuver as an important predictor factor actually. In this actually journals, they assess the capillometry is mandatory in selection. In the selection of uropalpoperium plus candidates, and the predictive model containing some or all of 4 variables may substantially improve the success rate. So this is one of the paper. So previously we used to take Muller's maneuver as a predictor for our surgical outcome. But in this paper actually, the Muller's maneuver is not one of the very good predictor. This is capillometry, do capillometry before surgery, assess all the body parameters to predict outcome. So sleep study, we know that actually our pulmonologist colleagues, they do sleep study for all this snoring patient and sleep apnea patient. So the sleep study is very important. What are the things we are seeing in the sleep study? That is very important actually. In sleep study, we see hypoxia, and a lot of obstruction, a lot of REM sleep, non-REM sleep actually. But what other things need is apnea hypopnea index. So the normal is below 5 or 5. Above 5 is we used to call as a sleep apnea. So oxygen desaturation index, this is very important for our sleep surgery. Desaturation index actually suppose below 60%, definitely patient will be a problem actually. Definitely we go to take a patient for surgery. And respiratory distress index also is important. All these parameters are very important. We have to look for in the sleep study. So in these parameters, with these parameters, we have to counsel the patient for surgery. So polysomnography and multiple sleep techniques test and CPAP titration. Nowadays, actually, we are not going for CPAP titration. A lot of patients actually CPAP failure cases, they are coming for surgery, and the intolerance to CPAP actually. They can tolerate the CPAP for at least 2 months, 3 months, but they can't tolerate. A lot of young couples actually, they are coming for surgery, so they can't tolerate the CPAP machine actually. So the CPAP failure, so it's one of the main indications for sleep study. So this is a gold standard investigation, vaginal sleep endoscopy. So vaginal sleep endoscopy is the role in evaluation of upper airway obstruction and patient selection for surgical and non-surgical management. This is both actually. So we can select a patient for surgery as well as non-surgical management. Simple airway collapse, only anteroposterior collapse. We will ask the patient to sleep in the lateral position as well as do simple exercise so they can do better without surgery. So this vaginal sleep endoscopy is one of the very good predictor for surgical outcome as well as non-surgical outcome also. Vaginal sleep endoscopy is a diagnostic tool that allows a dynamic 3-dimensional evaluation of the pattern of perforation and collapse of the upper airway of the sleep apnea patient. This may change the initial surgical plan in 5% of cases actually. So a lot of patients they used to come with snoring actually. So I'm running a sleep clinic. So previously once in a month getting a 1 case is very difficult. Now each day we are doing at least 3 cases. Last week almost I did more than 10 cases of sleep surgery cases. So nowadays the awareness is very high. A lot of young individuals, almost 20 to 30 years, a lot of people are coming for surgery actually. So that's why this sleep endoscopy is one of the main predictor for surgical outcome. Sometimes we do as a outpatient, this morning we do sleep endoscopy, ask the patient to see the sleep endoscopy result, and we will counsel them with the results. So they are actually happy, they can go for surgery. Otherwise, we do ask them to go for a 2 months CPAP trial and exercise, myofunctional therapy. After 2 months, we will assess the sleep endoscopy again. After that, we will take them for surgery. Otherwise, ask them to go for a sleep diet modification and exercise. So what are the controversies actually? Anybody knows about sleep endoscopy? Okay. So the sleep endoscopy always we have to do in the operation theater. Sometimes sleep, actually last week I told you 10 cases, one case is 145 kg. So actually the first sleep surgery is over, then post-operative we have to see them in the monitor them in ICU. That's how they are doing better or any collapse if they are. I was in the ICU. So this 145 cases actually, my junior doctor took the case inside. So always the patient used to sleep in a supine, not in the lateral position, as well as the prone. The anesthetist actually asked the patient to in a supine position. Once he liked the supine position, he started dexmet. Actually, 1 hour dexmet went inside, completely collapsed. Saturation is almost 16%. So suddenly we did a tracheostomy. So while they intubate, after that we completed the surgery. So this BMA is very important, as well as sleep endoscopy always do in the operation theater with high actually alertness actually. So sometimes they can go for a sudden arrest, saturation may fall even 16, 20%. We can't revive the patient. So always keep the tracheostomy set ready. Suppose BMA is very high. The controversy is vacuum sleep is not a normal natural sleep. So we are actually suppose previously we used to give a propofol, then midazolam. Now we are changing to dexmedetomidine. The propofol, the depth of sedation is very high. Then go for a sleep immediately, as well as the snoring is very high. Sometimes suppose propofol dose is over, the snoring pattern as well as collapse is very high. So we can't judge properly. That's why now we are doing dexmet. Dexmet almost given natural sleep. So with the natural sleep, when the patient starts snoring, we pass an endoscope through the nose. We will assess the salpingopharyngeal fold in the nasopharynx and velopharyngeal area, and below the velopharyngeal area, oropharyngeal area, then retrolingual area, then epiglottis and vocal cord. All these areas we would assess which areas causing collapse and maximum collapse. What is the pattern of collapse? Pattern of collapse is anteroposterior, lateral, circumferential. So all these factors we would assess in the sleep endoscopy. After that, we would plan our surgical method. Each collapse, each surgical method is important. So diabetic sleep endoscopy. So positional maneuver, already I discussed about this. Positional maneuver during dives assess the potential utility of positional therapy. Sometimes actually we give a jaw thrust, snoring automatically drops actually. Suppose give a simple mandibular advancement devices. So our dental colleagues, they are actually advising a lot of devices, dental ablations to this patient actually. So with these ablations, they are doing better. Knowledge of the collapse level on configuration enables customization of surgical plan. This is very important as a ENT surgeon. So always we look for some collapse, and according to the collapse and pattern of the collapse, we will customize our surgical plan. So this slide is important. These are the areas of collapse: nasopharynx and velum. Velum is just below the nasopharynx, and oropharynx and hypopharynx. Types of collapse already I told you: AP collapse, anteroposterior, and lateral collapse and circular collapse. So this is the lateral. It's anteroposterior, this is the circumferential. This is actually very difficult case. So we have to take out a lot of soft tissue. In this case, actually, this is a lingual tonsil. It's a tonsils, the epiglottis. So this lingual tonsil and lingual hypertrophy pushing the epiglottis back during sleep actually. This is a lateral collapse by the tonsil, the circumferential collapse, complete collapse, anteroposterior as well as lateral collapse. These are the types of collapse we go to assess during the sleep endoscopy. So this again the same. It's a circumferential. It's a normal airway. It's anteroposterior as well as mild lateral collapse. It's again circumferential. So this part is very, very important actually. Normally, we used to see all this level just above the tongue and just above the epiglottis. Once we see the epiglottis, we have to allow them to sleep for some time actually. So we can't decide immediately, just we will do the endoscopy for at least minimum 5 to 10 minutes. Then only when the patient goes to sleep, curtains are there actually. Mild sleep and it's moderate, they will go for a deep sleep. And deep sleep, we would assess the epiglottis. Epiglottis normally sometimes it won't go and collapse. Sometimes it will go like flappy epiglottis like this, go glass over the posterior wall, completely it will give a collapse. And this is the epiglottis, is a coding epiglottis. Sometimes it will, because of the negative pressure, it will come and touch together, give a complete collapse. It's also epiglottis collapse because of the huge lingual tonsil pushing the epiglottis back, causing complete collapse. So this is one of the dice. Making the sleep endoscopy. We are pausing the endoscope inside the nose. And this is the nasopharynx. See, this level, there is a complete collapse. And suppose there is a solving of pharyngeal fold. Behind this solving of pharyngeal fold, our carotid artery is there actually. So we can't do anything in this area. There is also solving of pharyngeal fold. So there is a classification by our Indian friend actually. So type 1 to type 4. Type 4 is very dangerous. We can't do anything. The only possibility over this area is a channeling. We pass a coagulation channel or radio frequency channel over this area. We can reduce this thing. Even channeling also very dangerous because carotid artery is very nearby. Suppose we injure the carotid artery, it's very troublesome. We can't control the bleeding. So in this case, it's very difficult. In this case, we have to do only what is the only option. This is a mandibular maxillary advancement. MMA is the only option, very good option over here. So we pull the maxilla anterior as well as mandibular anterior, so they can get a good space. Okay. It's another sleep endoscopy. So in this case, actually solving of pharyngeal fold is very good actually. This is a bula. Saturation, sorry. So this is bulas causing complete collapse at this level. At this level, you see the saturation is only 79. So once you pass the scope behind, you are able to see the retrolingual area, huge lingual hypertrophy, pushing the epiglottis back. In same patient, 2 or 3 level of obstruction may be there. They have to assess in the sleep endoscopy. Otherwise, we will miss the level of obstruction. Definitely, we can't give a good result. So the assessment in sleep endoscopy, so in 5 levels. One is nasopharynx, and the velopharynx, oropharynx, and then the tongue base, and below the tongue. So normally, this is this thing, multi-level obstruction, the area of obstruction. So velum is almost contribute more than 80%. Then oropharynx, then tongue base, and epiglottis, and lingual tonsil. But in same patient, suppose multiple obstruction is very common. So each patient, they won't give only velum obstruction. So the same patient, they have a multiple obstruction. So multiple obstruction contributes more than 80%. So only unilevel is very less. So always we have to do multi-level surgery in single patient, in single setting. So we can give a good result. So this selection of case. So according to the American Academy of Otolaryngology, studies show that is this procedure, each procedure, they can give only 60% of result. So multi-level surgery is the goal. So these are the surgery we are doing for sleep apnea. So there's a lot of surgeries are there. Oropharyngoplasty, one of the commonest method we are doing regularly. So tonsillectomy and mandibular advancement, genioglossus advancement, hiatal suspension. But only the highlighted surgery, so we are doing regularly. Maxillomandibular advancement is for very severe cases. Midline glossectomy, almost more than 50% of cases. Zeta-plasty, otherwise zeta-palpoplasty, tongue-based coagulation, and expansion sphincteroperineoplasty. This is the commonest surgery nowadays we are doing regularly. It's otherwise called ESPP, expansion sphincteroperineoplasty, and transverse robotic surgery. So now we have a Da Vinci system on PAG and bobbed pre-pushing perineoplasty. And Capasso method is otherwise called cautery-assisted vulvopalatoplasty. Cautery-assisted vulvopalatoperineoplasty or palatal stiffening operation. Epiglotopexy, epiglotoplasty, hypoglossal nerve stimulation, but no FDA approval in India. But still in US and Europe, there are a lot of cases that they are doing regularly. So what are the key to success? So this slide is important actually. Which method for which case? So this is a very important slide. DICE plays an important role and level of obstruction, multiple procedure in single patient. So this is the mantra to achieve a good result. Now we going into this each surgical step. Vulvopalatoperineoplasty nowadays nobody is doing, means actually only vulvopalatoperineoplasty won't give any result actually. So selection of cases, if there is no tongue enlargement, tonsil size 1 and 2, this is the ideal method actually. Tonsil must be small and this palatal redundant palate and tongue involvement. So no, actually no tongue involvement. So you can go for a vulvopalatoperineoplasty. Nowadays we are doing a modified vulvopalatoperineoplasty. So reduce the posterior pillar too much, almost reduce the posterior pillar and close stitch the posterior pillar towards the lateral perineal wall with the superior consider muscle or maybe tonsillar this bend. So give a good result. Primary stage 1 is a strong predictor of success after utility. Well, primary stage 3 and low higher position are negative predictors. So nowadays, so this is not only surgery for sleep apnea, this is a part of the surgery. So going to the Z palatoplasty, so this is another common surgery. Give at least 90% result in all patients actually. Nowadays, actually all these snoring patients, they used to come with no tonsil. Tonsils almost nil because actually they underwent tonsillectomy in the childhood. So this tonsil actually, so you put a very good tonsillectomy, but after the tonsillectomy, you follow the case maybe after 6 months or maybe 1 year, you're able to see there is a narrowing of the lateral perineal wall. This posterior pillar, actually there will be a lot of fat deposition of the posterior pillar. Posterior pillar almost comes close together actually. So this tonsillectomy is very good tonsillectomy, but actually they can develop later on for a sleep apnea. So in this patient actually, so no tonsil, but there is a collapse of actually huge collapse of soft palate level. This is the method of choice. There is no tonsil, so we can easily avoid the patient. No tonsil, but why we are snoring, go for walking, but they will so collapse too much actually. So this is palatoplasty, give a very good result for this patient. Patient without tonsil and primary tongue position 3 and 4 are poor candidates for QP3. That is, these are good candidates for izetoplasty. So we go to the surgery. So this patient actually complete collapse. Play. So the soft palate collapse is too much, as well as lateral collapse. Maybe very minimal tonsil. To the collapse at the lateral phalangeal level. So this is action research index is more than 60%. This forward click on forward. So the purpose to increase the lateral pharyngeal area as well as anteropharyngeal collapse also. Go back. So this is actually incision, is a butterfly incision. So we cut the uvula in the center, reduce the soft palate thickness, make it two flaps and stitch the two flaps laterally, the pterygomandibular area. So it gives a very good lateral widening as well as anteroposterior widening. So we use coagulation for this method actually. So everybody knows about coagulation. Coagulation is only it's a plasma energy. So only 50 to 60 degrees Celsius of heat. You know that laser is 300 degrees Celsius, is only 50 to 60 degrees Celsius. The normal saline is a conductor medium. Once a normal saline comes and touches the electrodes, it forms a glow, is a white glow or a yellow glow, it's a plasma, it cuts the tissue actually. So healing is very fast, the pain is also very less. That's the advantage of coagulation. So the single one, they have a coagulation, suction, as well as ablation. That's the advantage of coagulation. Nowadays, we are using for all ZNS surgeries. So raise the flap like this. So remove the excess soft tissue. No bleeding at all. So even though there is a bleeding, with the same one you can violate the area. Split the uvula in the center. Now actually this one. And we extend the incision into the soft palate. Suppose you think and the soft palate thickness is very high, you can take out the tonsillar fat actually, supratonsillar fat actually. So this muscle is a palatopharyngeal muscle. You can reduce the palatopharyngeal muscle. Palatopharyngeal muscle forms the posterior pillar. Palatoglossal muscle forms the anterior pillar. We can reduce the palatopharyngeal muscle a little bit. So this is the main culprit for snoring actually. So this palatopharyngeal muscle, so during snoring, it will go and collapse in the posterior pharyngeal wall, cause complete obstruction. Normally, we go to reduce the palatopharyngeal muscle to get a good result actually. So now this is a zygoplasty. So we are now stitching the two flaps together. Like this. The chances of bilopharyngeal insufficiency is very common, but you won't believe actually after a month actually. So they feel better. There will be no aspiration of water in the nose. There's new soft palate actually. So go and collapse the posterior pharyngeal wall. So it will act as a new bilopharyngeal sphincter. So this is one side. The same method we are going to repeat the opposite side. So approximating the flaps. So this is channeling. So suppose you think the posterior pharyngeal wall thickness is more, then you can do a channeling in this area. This is another coagulation one. Reflex ultra one. We can pass in the posterior pharyngeal wall. We can pass the coagulation energy for 12 seconds. So we can repeat 2 or 3 sittings. So definitely the patient will do better actually. So this is the starting area. See, this is the final result actually. This much of space we can get post-operatively, even though there is a little narrowing, patient they will do better actually. This expansion sphincter perineoplasty. So when there is a lateral collapse is more, this is the surgery of choice. So reduce the lateral pharyngeal collapse in patient with a moderate or severe OSC. Clinical data suggests that both severe palatal circumferential narrowing and bulky lateral pharyngeal tissue are favorable surgical indication for this expansion sphincter perineoplasty case. Narrowed oropharynx due to lateral bulk of soft tissue around the posterior pillar as well as circumferential narrowing. In dice, next there's a grading system is there. Grade 3 at the retropalatal level. This is an indication of in the expansion sphincter perineoplasty. So this is the surgery. So moderate to severe OSA. The plan is to increase the lateral pharyngeal wall like this. In this case, we do tonsillectomy first. Once you remove the tonsil, so this is the palatopharyngeal muscle. We detach the palatopharyngeal muscle from the rest of the palatopharyngeal muscle from the posterior wall. Like this actually, the coagulation, even you can do a bipolar artery or monopolar artery or radio frequency, this thing. But this coagulation pain is very less. Healing is also so fast. So like this, we can separate the palatopharyngeal muscle. Then pull the palatopharyngeal muscle and stitch the palatopharyngeal muscle to the pterygomandibular raphe action. So like this. So suturing is little difficult for beginners. So once you master the surgery, so it's very, very easy. So we won't believe this is one of the surgery give a very good result for all sleep apnea patient. So nowadays they are doing this lateral, otherwise called lateral perineoplasty. Michael Kagalif designed this procedure. He coined this as a lateral perineoplasty. And after that, actually, this Kenny Pang and Tucker Woodson, they designed, so this suture this muscle to the pterygomandibular, this thing. They put it as an open manner, but that was a closed thing, it's a mucosal preservation. So otherwise, so now they used to call this expansion sphincter perineoplasty. You take a bulk of the palatopharyngeal muscle, then suturing the palatopharyngeal muscle to the pterygomandibular raphe. This is the pterygomandibular raphe. So you have to pass the needle behind this and take out the needle, and the same way you have to go by the same way. The burying stitches. See, like this. This much of fullness we can give, we can extend, and we can widen the lateral pharyngeal wall like this actually. So 2 or 3 stitches we can do it. Pain actually, the pain is little more post-operatively. So with any other method, even coagulation also, the chance of pain is more. But actually won't believe actually the patient, they will do better once they start eating, pain will disappear. So one of the another way of reducing this in all this ESPP as well as etaplasty, the patient definitely they will lose at least minimum 5 to 8 kg. So like this, 2 or 3 stitches. So this is The same method we are going to repeat the opposite side. One side is over now, so the same method we are going to repeat the opposite side. Like this. And so the final picture. This is the final. Actually, there is a little tension is there. Once we remove the mouth, then the tension will go. Okay, this is the final result. Always we cut the uvula, so we won't leave the uvula behind. So we will partially cut the uvula. So uvula is the natural viper of oropharynx, but suppose we leave the uvula, definitely soft palate collapse, anteroposterior collapse is more. So always you have to address the uvula in all cases, otherwise you can't give a good result actually. So this is the final result. This much of space we can get. This is the previous one. So lateral collapse. This is the final picture. So it's a very good lateral winding. So this is otherwise called expansion spectroperineoplasty. So bobbed reposition perineoplasty. Actually, a lot of Italian guys our friends are doing a lot of bobbed perineoplasty. It's only suturing. The thing is actually we go to create inflammation in the soft palate, and the soft palate aggregations will pull this this thing, soft palate anteriorly as well as superiorly. It will create a space in the middle level. Only obstruction at the level of retropalatal level. This is the method of choice, but it's for very simple snorer, not for a sleep apnea patient. For simple snorer, definitely do better. But the chance of recurrence is very high. We go to repeat at least 2 or 3 times, maybe once in 6 months or maybe one thing. The cost of the each suture is 25,000 rupees actually. Still is not very much available in India, but still our Bombay colleagues are doing regularly. So you know the Bombay, Delhi, Bangalore, even simple snoring is not acceptable. So a lot of guys are doing this outpatient procedure. As we do in the morning, we can discharge them in the evening. So the next comes the midline glossectomy. So in this patient already I addressed the soft palate. See the address soft palate. After that, actually, huge time. The thin guy, beam is only 30, weight is around only 70 kg. So he choked 2 or 3 times actually, as well as he met the accident during travel. After that, they came to us. So we assessed the maxillary endoscopy. We found out the tongue base is causing collapse. But we are doing actual midline glossectomy. With the coagulation, we got 71. Eventually, we can reduce the tongue thickness also. The posterior diameter is high, as well as the bulky tongue. With this, actually, we can reduce the tongue thickness. So, tongue is a highly vascular structure. So, the coagulation, actually, we can do without any bleeding. So, it's totally avascular field. Once you see the sign of bleeding, so at the area of you are reaching the lingual artery, we go to stop it. Otherwise, there's a major bleeding. It will produce post-operative hematoma. So definitely they will go for a collapse in the ICU ward. We go to intubate them for at least 2 days to reduce the edema. Once you strictly limit to the area, so if there is no bleeding, definitely you are not in a danger place. Always the lingual artery enter the tongue base in lateral position, not in the midline. So this is the idea. So once you reach the sign of bleeding, so you reach in the vascular plane, you have to stop it actually. This is also tailor-made surgery. The volume of reduction is according to the each surgeon, according to the each patient to the collapse. So this is actually almost removed more than 5 centimeter depth. Still there is no bleeding. So this is also very good actually. We won't believe there is a no pain at all for this patient. Actually, all this was nerve endings are cauterized with this ablated with this coagulation. So there is no pain. Even though no pain, we have to give a painkiller 4 times daily. There is 2 way of schooling is there. One is actually just leave it like that. is a tunnel for airway. So won't be a collapse. The other school of this stitch the area. The stitching is actually, I used to prefer because actually, so otherwise after each time of food actually the food particle won't lodge over the chance of infection is more. That's why we used to suture finally. So the suture technique actually reduce the diameter posteriorly as well as the thickness posteriorly. So they can do better. This is the final this thing. So this is the midline glossectomy. This is a epiglottic collapse actually. Suppose we see any epiglottis collapse. See this epiglottis is very floppy. Complete collapse at the level of the epiglottis. And go with endotracheal tube. See the collapse of the epiglottis. Definitely this patient, the epiglottis fall backwards and completely occluding the airway during surgery. So this epiglottis we have to address. Otherwise, we can't give a good result. With the coagulation, we can saucerize or we can remove the excess flappy tissue. We can sometimes cut the cartilage also. Luckily, these days, there won't be no edema. Pain is also very less. They feel some body sensation, that's all. The coagulation is a very good tool actually. So this with the same one you can violate that area, so you can get a very good result. This is with the direct laryngoscope. This is the 45-degree endoscope. Sure. So the final visit in this patient. So this is the final result. So we're able to see the endotracheal tube very clearly. So only cartilage is there. So they will do better. In this patient, lingual hypertrophy is also very high. We can reduce the lingual hypertrophy also with the coagulation one. Likely there won't be any this thing edema post-operatively. So in this case, actually, this is the 45-degree. We can cut the epiglottis like this. They can do better actually. So that's why actually I used to tell this multi-level surgery. In single patient, multi-level obstruction, you have to go for a multi-level surgery in single patient. This is one of the post-operative epiglottis resection case. So there is no aspiration at all. So they will do better. Even the false card, they will come and collapse. Aspiration chances are very less. This is the post-operative sleep endoscopy showing the not a real scopy, not a sleep endoscopy. They can do better actually. So vocal cord levels, sometimes actually we are seeing this type of patient. Actually, they are coming for only snoring. Actually, in this patient, congenital abductor paralysis, both cords are in adducted position. So this is a 25-year-old male actually. They came with snoring, actually no stridor. Actually, he is a BE student. He recently joined as a lecturer down college actually. So this actually came with a history of snoring. This is a congenital abductor paralysis. Both cords are in adducted position. In this case also actually suppose we so with a very high suspicious only we can detect this type of cases. Otherwise, we won't look for any vocal cord collapse. So in this case, actually, suppose vocal cord collapse, we know that there's a modified Casimas operation. So we pass the endotracheal tube on one side of the vocal cord. We reduce the vocal cord like this. only the posterior two-third. So remove the posterior card. So I'm actually doing for early cancer, bladder cancer population correctomy. We used to remove complete cord one side, we go up to the thyroid cartilage. They will do better actually. Instead of going for a total laryngectomy or radiotherapy, they can do coagulation correctomy. Is one of the things. As I presented this paper, this thing is very well appreciated. Still in Sunnyvale Laryngo Journal, the topic is there. So this is a post-operative area. So definitely they can do better actually. So this is genioglossus advanced. Nowadays we are not doing this actually. So this is genioglossus muscle. So if there is a tongue-based collapse, so we make a window like this and pull this genial tubercle towards anteriorly and rotate and stitch with the nail and screw. So this is maxillary mandibular advancement. This is one of the 100% results with this method. So we are actually this mobilization of maxilla anteriorly. It will advance the retropalatal area as well as will pull the mandibular anteriorly. It will advance the retrolingual area. So both retropalatal, retrolingual advancement is there. This is a preoperative. See the collapse in this area. This is a postoperative. Able to see the widening is the retromaxillary. Retropalatal widening is the retrolingual widening. So not last but not least actually, role of nose is very important actually. Suppose you not address the nose, definitely you will land in failure. So this deviated nasal septum like this and huge turbinate, always do septal surgery along with this sleeve surgery, reduce the turbinate, you can give a good result actually. So this other paper can sleep apnea implants, hypoglossal implant. So when I was in US with the Stanford University, the sleep, Stanford is one of the very known for a sleep surgery. This thing. When I was there, actually, this hypoglossal implant actually they are doing at least daily, at least 2 or 3 cases. There's a not very non-invasive method like a pacemaker. We used to keep this thing, the implant like this. The electrode goes and round of the hypoglossal down. Whenever there is a discomfort in the chest movement. So this disorder breathing, it will stimulate and it will stimulate the hypoglossal down and pull the tongue anteriorly. This is the mechanism. Surgery also very simple. We make a tunnel subcutaneously just below the skin and fat and pass the electrode inside. And the neck, we make a 2 incision. The another incision, we find out the hypoglossal now at the level of neck. And there's a small electrodes, there's a pin like this. And we surrounding the like a cochlear implant, we will place the electrode inside the hypoglossal now. There's a small screw like thing will be there. And the nerve pass through the screw. Whenever there is a disordered breathing, they give a signal to the electrodes, and the electrodes pull the give a power to the muscle. The muscle will come anteriorly. They will protrude the tongue actually. But it's a little troublesome this thing. But acceptance in US and Europe is very high. They are doing in large number. The near future is actually the implant which stimulate radial pharyngeal wall, but they stimulate only the tongue base and pull the genioglossus muscle anteriorly. It will give a very good space in the retrolingual area. But near future, suppose any implant which pass the energy to the conceptor muscle. The conceptor muscle causes the lateral collapse. Even though retrolingual space is very less, after that actually there is a forming a tube is mainly because of the conceptor muscle. We pass any energy, this lateral conceptor muscle, so go away. Definitely they will do better. This is the near future. Still the work is going on. Even our Indian colleagues are actually working on this. This post-operative management, all weight gain, drugs and alcohol, long-term effectiveness therapy, and determinants in polysomnography. We ask them to go for a sleep study after 6 months, after 1 year. Just follow them actually. Determination of the surgical access. This is very important. Myofunctional therapy. So even simple snore, myofunctional therapy definitely do wonder actually. It's a very simple exercise. Ballooning actually regularly blow the balloon. keep on blow the balloon. Even though you go for walking, cycling, swimming, there is a reduction of weight, but there is no reduction of fat in the soft pellet area. So myofunctional therapy is one of the very good method actually. So you can do a myofunctional therapy. Just rotate your tongue and swipe back to the palate. Pull up. So you give a very good contraction your palatopharyngeal muscle as well as palatal muscle. So automatically, suppose you do 10 times or 20 times, 100 times in a day. Within a week, you feel the difference. The snoring will go away. As well as keep on blowing the balloon. So it will give a very good exercise for your oropharyngeal musculature. It will give a very good contraction. The oropharyngeal, it will increase in diameter. Definitely, the collapse will go away. So these are the myofunction exercise. Push the tip of the tongue against the hot palate and slide tongue backward 20 times. Suck the tongue outward against the palate. Pressing the entire tongue against the palate 20 times. Force the back of tongue against the floor of mouth while keeping the tip of the tongue in contact with the inferior incisive teeth. Elevation of the soft palate and uvula. These are the simple myofunctional exercises. All are available in the internet. So these exercises also for simple snorer, definitely they will do better. So these are the like ballooning, tongue exercise. So this apnea-hypopnea ratio, suppose you do multiple level surgery, definitely there's reduction in 80%. Single surgery, so only we can get a 40 to 50% result. Thank you so much. Yeah.
Very nice presentation, Dr. Anand. It's after a long time I witnessed one of the best video presentations recent times, OIC surgeries. Now we'll do question session. So we have undergraduate, postgraduate, students also. The problem is same, it is snoring and sleep apnea. We have various level of doubts from the undergraduates, postgraduates, consultants, practicing consultants also. To start with the undergraduate, we are looking starting from simple tonsil surgery, septal surgery. We go for one of the baselines for OIC surgery. To the consultants, they have tools, lot of tools. We have a great armamentarium, starting with laser up to the problator, up to all the different things. And which area, which tool you fix? That is my one question. First question. We have a lot of tools. Number one. Number two, the post-operative complications. Most of the patients after palatal surgery, they go for adhesions, aspirations, lot of things. And how will you manage in such situation? Failed palatal and failed surgeries. Number two. Number cost factor. Cost, because the sleep surgery, sleep lab, and sleep clinic. Probably nowadays we need a sleep clinics also. We have assessment, we have a follow-up surgery, we need a big setup. So in our experience, vast experience recent times, how do you manage all this?
Actually, so I agree with Dr. Jason. So we started with sleep surgery 2009. So I told you, so I used to get only one case, sometimes even 6 months, only one case. So counseling the patient is very, very difficult. So even though they will go for a weight reduction and BMI reduction, the results won't be proper. So apparently after 3 months, they will end up with severe snoring. So acceptance level is very, very less actually. So I did my first surgery, my cousin. So keep on actually nagging him actually, as well as my his wife actually my supporter. So I keep on nagging him. So go for a surgery, very good result actually. He accepted, they underwent surgery, so still they're doing fine. So they brought a lot of patients actually. So like that actually. So the cost, the tool like this actually with a simple monopolar artery do wonder. So that is enough for this surgery. So no laser, no coagulation, simple monopolar artery. But the only problem is, so it's a time consuming, so painful, chance of bleeding is very high, post-operative pain is very high. So after that, definitely they won't come for any revision surgery. They won't give any acceptance to, they won't give any counseling to any patients. So normally what I do actually, if any snoring patient comes, I will give my patient another previous patient number. So just talk to this patient, they will give a proper opinion. So you just talk to them, now they will come. All patients do like this, we have a list of patients. So very good patients. will give the number of the patient will counsel for me. So that is the thing actually. So you can use, nowadays nasal is not very costly. Dialysis will come in 6 lakhs. So suppose you want to get a good name and good practice, definitely you have to sacrifice something. So without sacrifice, anything won't come actually. So to sacrifice something, definitely you can choose something. So you invest. ENT is a very good, it's a very high investment. So you have to buy a microscope for at least 25 lakhs or at least 15 lakhs. 5 to 6 lakh microscope nowadays. So it's very less. You can't give a very good result. You want to do cochlear implant or do any major cell-based surgery, definitely you have to go for a very good instrument. So the instrument nowadays on bank, they are giving a loan, so definitely you can start a good practice. There won't be a problem. So each area, this already all coagulation we can do, even from nose, tip of the nose to tongue base, even vocal cord, we are using coagulation. Coagulation is not very costly, so it is cost-effective instrument. The only problem is the replacing wand actually. So the disposable wands, each wand comes around 10,000 rupees. Little costly. So you can do a sterilization and you can do it for each wand. You can use it for 2 or 3 patients. So complication sense it's not very much. Thing is severe pain. Aspiration will be there. You got to give a pre-operative list of complications. I used to give a small paper as a printed paper. These are the complications. There will be mild voice change in silly. Will be pain for at least a week. Weight reduction as well as the aspiration through the nose. So once aspiration there is a good surgical result. You have to give a counseling like that actually. They will accept. Otherwise they won't accept. Next day morning also they will come and stand in front of the clinic. So so initially we face all this problem, but now everything is acceptable by the patient. So even the first day, night itself, there will be no snoring. So the saturation we used to monitor with the monitor. The BP is also starting going to normal BP. Saturation is always above 90. So definitely they will be happy. So the chance of recurrence is less, but it's won't going into the previous level. The chance of snoring will be there, but we have to follow them. So we have to call them actually. So 3 months, 6 months, you have a snoring resistant. We'll ask the junior doctor to call them and ask them to follow regularly. So this type of thing you have to follow to get result. Otherwise, it's very difficult.
Thank you, Dr. Anand. So it's a wonderful presentation. You almost covered all aspects of the sleep surgery. Actually, you have shown all the surgery by coagulation. We don't have a coagulation, but we have a RF. Actually, during that time, we had a debate whether to go for RF or the coagulation. The problem is the wand, as you mentioned that you have to replace it. So, whereas in radio frequency, with the one probe itself, we can able to do a lot of surgeries. That is why we went for that RF. Can you please tell us something with the help of the RF? What are the things we can able to do?
Surgeries, not you know that you are doing with the RF. So the gitaplasty we can do with the RF. And the expansion sphincteropharyngoplasty is also we can do with the RF. Only the tongue base and the epiglottis and the lingual tonsil area, definitely RF won't work actually. The chance of bleeding is very high. Definitely at that area you need a coagulation one actually. Even vocal cord, so you need a coagulation or maybe carbon axle laser. Laser also is little difficult, very costly, and you can go with the coagulation. All surgeries except tongue base, epiglottis, and this lingual hypertrophy. So we got another case, ectopic thyroid, huge ectopic thyroid causing complete collapse. So it's a newly married girl actually. So came with severe snoring. So we did a ectopic thyroidectomy. So lingual thyroid.
I think for tongue place also, with the help of RF, I think we have a channel like this, but we didn't have that.
The channeling, the problem is recurrence.
Recurrence.
You have to reduce the volume of tissue, otherwise you can reverse the result. Channeling we can do 3 times, 4 times. With zap pellet channeling we can do, but results are very poor. You have to reduce the volume, thickness of the soft pellet, otherwise you can't have a good result.
Okay. One more last question. Is it about myopharyngeal exercise? Yeah. So how far it will be helpful to the patient?
No, it's a simple snoring. BMI is very less. this ODA is actually above 70%. Not the goes below is the danger. 70% is acceptable. Respiratory distress index is actually 80 is dangerous. Simple snorer, BMI is actually within 25 to 30 or 35. You can ask them to go for myofunctional therapy, definitely. And my advice is all this post-operative patient, we advise myofunctional therapy definitely helps a lot.
So do you have any video of that? Do you have?
Yes, we have actually, but it's not included in this.
Okay. So after that, we share with others also, so that it will be a simple one. Probably, as you mentioned, that the simple snorers without doing any surgery, weight reduction, and this myophalangeal exercise will definitely help. Thank you. It's a wonderful, wonderful presentation.
Questions are from my students, consultants, postgraduates. Please ask questions. Feel free to ask questions.
Thank you so much for the lecture. So, is there any role of chemotherapy in OAC surgery?
Nowadays, these surgeries are more superior than chemotherapy. Chemotherapy, the thing is, the stiffening is too much, and the collagen perforation is very common. So, what is nobody doing?
Good afternoon, sir. Thank you for your presentation, sir. My doubt was regarding the hypoglossal nerve stimulation, sir. How effective would it be in all patients, even with high BMI patients?
That's why US actually they are advising for everybody, even though for BMS, results like they publish more than 100 cases. What they are telling, even though BMI is high, BMI low, it will stimulate the tongue-based retrolingual space. So the retrolingual space is more, W scoring is less. So they are advising for all patients. Cost of the implant in India is perfectly. India approval in India is not there. Luckily, can't do it. It is also the same pacemaker mechanism. The pacemaker is only for even 1 lakh, 2 lakh. So some PhD to their e-contact to make a friendly
medical management and surgical techniques in managing devices.
So you know that actually medical management only for nose blocks, huge tonsil and polyposis and allergic rhinitis, they use for this case medical management definitely helps. So you have to give a trial of steroid spray and antibiotic. Technically, they are actually patients. They are talking about sleep apnea patients. Sleep apnea patients, medical therapy is no use at all. Only using exercise, weight reduction, or steady research.
Patients with circumferential collapse, the patients are not fit for surgery. What are the other treatment models?
They're not fit for surgery. We can do the circumferential, anteroposterior, lateral collapse. You can address both. That's why it's actually each method I'm showing this thing. So in single surgery, we will address all these things. We address the soft palate, we cut the ulna, the lateral ESBP, along with the lateral anterior calvoplasty. Procedure we will address all in single patient. It's not a contraindication, but little more surgery.
Hello. Good afternoon. Thank you for the presentation. Just wondering, patients, as you said, patients recently have started coming to surgeries even if they have some simple snoring complaints. So even patients are tolerating bypass or CPAP. Where do we keep the cutoff to consider surgery?
Patient Actually, he is doing better with the CPAP. But he's a young chap, actually 30, only age is 30, recently married actually. With the CPAP, they won't tolerate actually. So the tolerance level at the family and the complaints with the mask is very tight. And they will go for a claustrophobia. The dryness of mouth is more. They can't take the machine back wherever they want to. Old age, above the age of 60 or above the age of 70, retired people, they can do better with the CPAP. The young individual, they can't tolerate the CPAP. So this is actually, suppose they do better with the CPAP, we will advise them to go with the CPAP. The first advice is, suppose better with the CPAP, they can do better with the CPAP. If not able to tolerate, they will compensate.
So questions are over. Any?
On behalf of everyone here, I would like to thank Dr. Anand sir for such an insightful session and walking us through so many surgical videos, sir. Thank you, sir.